Hello, everyone. My name is Goce Ristanoski, and I'm a researcher at the University of Melbourne here in Australia, where it's currently nightfall, and we were actually quite hoping that we will be able to attend the conference in person in Portugal, because I have been to Porto, and it's a wonderful city with obviously very great hosts, but hopefully for the future. My presentation today is focusing on using primary care datasets for lung cancer detection, and it's an AI-led approach. So I will start my presentation by describing some of the cancer that we're using, the cancer diagnosis that we use using primary care dataset and the related research, and how our approach different from what people usually are doing today. That will also describe the dataset that we're using, the NPS Medicine Insight data that is actually part of the Victorian Comprehensive Cancer Centre here in Australia, and how several of the metrics that they think are quite relevant for analyzing the cancer actually do show potential to be used in AI models. I'll also describe some of the features that we're using and the machine learning models that we've chose for our task. And at the end, we'll complete with the results and how we can improve this work even further. In Australia, we have more than 150,000 actually cases of cancer being diagnosed every year. Luckily, most of them in a way is with skin cancer, but also we have the other types of cancer as well. And for all of these patients, the first contact with the medical professionals is with general practitioners or GP. That is actually what usually happens with all the other medical conditions that we experience. We usually go to the GP, and if it seems to be something more serious, we get a referral to go to a specialist. What this means is that general practitioners actually are in a very good positions where they can really speed up the early diagnosis of the more serious conditions if they actually utilize all of the data that is available to them, and they do actually have quite a lot of data. Our challenge when it comes to cancer is that it can often have non-specific symptoms, which means that if the GP uses symptoms as a way to make a decision, it can really be a bit more challenging if the patient is not experiencing symptoms in the early stages of cancer, and usually it can happen in the more delayed stages of cancer. However, obviously we want to be able to detect the cancer as soon as possible. And from all the non-melanoma types of cancer that we have in Australia, lung cancer is definitely one of the most common one. I think it is in fact actually the most common types of cancer that we have. And there has been research that have associated several different metrics from the blood tests, such as anemia or the platelet counts. If it's too low or too high, it has been associated as kind of like a red flag for GPs to maybe have additional tests taken for the patient and make sure that there is no cancer. However, it is not totally utilized to the full extent. And if we want to actually utilize this completely, we need to look back in the patient's history, not just the most recent visit, but actually as back as possible, even up to 2 years. And the way to do that is to use pathology tests. Pathology tests are actually quite readily available for GPs, which means that that's one of the data that general practitioners can use in order to decide on decision support tools. So what we decide in our work is to investigate if pathology results, in particular blood tests, can be associated with cancer, and if can be associated with cancer, if it is possible to use them in order to deliver 3 or possibly even 6 months early ahead diagnosis for cancer. Now, current practice is usually focused on something like 3 to 4 months ahead of cancer, depending if there is some kind of symptoms that are present with the patients a bit in advance, and we are trying to at least match that period or possibly extend it even more. The way we are doing this work, it can be both applied for 3 months, 6 months ahead, or even 9 months to 1 year ahead, depending obviously on the quality of the data or the research findings that we find with this data set. So what we will do is we will show how irregular or infrequent data actually, when it comes to pathology, can be used for cancer diagnosis, and we will define a more consistent set of metrics and features that can provide us with good quality data that can be used for AI models, and how these data can actually be also applied to other types of data or extended to additional metrics. To briefly describe the NPS Medicine Insight data is a data set here in Victoria, which is one of the states in Australia, of more than 500 GP practices, almost just under 2 million patients and more than 85 million pathology records. And it is part of the Victorian Comprehensive Cancer Center, which are our collaborators here at the University of Melbourne. And the metrics we'll be investigating and trying to see if they are associated with cancer are platelet count, the mean corpuscular volume, mean corpuscular hemoglobin and hemoglobin concentration, as well as the red blood cell distribution width. So we're starting with these 5 metrics. Our latest research has actually added even more metrics with even much more improvement in the results, but the initial ones that actually provide quite good forecasts for up to 6 months ahead are these 5 metrics. So what we suspect is usually, we go to the GP's office and the GP will look at some of the symptoms, some of the maybe in the medical background, and they will provide a suspected diagnosis for cancer. And that is actually the very first diagnosis we have for cancer. Once we actually had a referral to a specialist and we confirmed that is the actual diagnosis date, but we are using the first suspected diagnosis date, which means that every time we provide a 3 months forecast for patient, it is in fact 3 months at least forecast compared to the current practices for determining whether or not a patient has cancer. And what we are looking is relative to this suspected diagnosis date is the pathology tests of up to 2 years in advance. In particular, we were trying to see if the metrics listed earlier have been occurring and how often they've been occurring, as well as grouping them in a 3 or 6 months period just to see how they progress over time. Patients actually have shown to have increased the number of visits as well as the number of pathology tests and other range values for these metrics in the period just before the initial cancer diagnosis date. In fact, we can see that for most of the non-cancer patients, which is our control group, we have almost 100, and around 96% of those patients have maximum 1 out of range values in the 2-year period for these 5 metrics, while the cancer patients actually have 2 or more actually out of range values for more than 20% of the patients, which means that there is actually good indication that a patient may experience an out of range value for at least one of these 5 metrics. Not only that, we can see that if we look at the pathology tests just before the diagnosis date, for the patients that did experience an out of range value, it is more likely they will not actually survive the cancer. Their disease mortality rate is quite higher compared to the patients that did have cancer but did not have an out of range result for these 5 metrics immediately before the diagnosis rate. So not only that we're able to associate these metrics with lung cancer, we're actually able to determine the most important patient cohort, which is the high-risk patients of not surviving the cancer, and focus our research also on them additionally if we need to. So what we did is we used these 5 metrics to design features with both quantitative representation based on the number of occurrences, as well as time-based representation based on how often they occurred within 3 or 6 months period prior to the suspected diagnosis date. And we also added details about patients' age group, biological sex, as well as whether or not we have some history in the family with cancer. And we finally combined all of these features with these metrics in a more innovative way in order to see if there is actually some correlations between the metrics themselves. For example, if MCV and platelet count together are actually more indicative of cancer than on their own. One of the things that we actually also did was we introduced a soft out of range border. So what happens usually is for these metrics, when we have an out of range value, usually that can show up like a red flag in a way in the report to the GP, and the GP will have a very good look at it because it's properly marked. However, if it's still within the normal range of values, but very close to the border, particularly the end 2.5% or combined to the 5% at the end of the range, then it will not show usually for the GP, which means that I can just ignore and still consider it to be a regular result. However, we did notice that a lot of the patients experience values for the metrics within this very far end of the standard range, and we wanted to make sure that that's also included and considered every time we are analyzing this data. And this will actually allow for more patients to be included in our analysis, because for this work, in order for our patients to be considered to be classified as part of this model, they would actually need to have at least one of the metrics to have out of range values Otherwise, if the patient doesn't have out of range values, they will not be able to be assessed with this model. And that can, most of the time, that actually occurs not because the patients haven't experienced out of range values, but because they actually haven't had many pathology tests, which means the quality of the data here is very important. And that's one of the things that we should consider pushing more for the patients, especially if they may be suspected they may have lung cancer later on. For example, patients who regularly smoke, for them to have quite regular blood tests taken throughout their life. The machine learning models that we'll be using are most of them from the decision tribe family, which is decision tree, the AWS, the light GVM as well. And we are going to be using them because if we want, we can actually visualize the output of the model and see what is interesting about the results. And we're also going to combine them within an ensemble and a stack form. For our models, we use 10 cross-fold validation using between 41 to 54 features. The results that are reported, actually, most of them within this feature range had very consistent performance. I think the standard deviation of the accuracy was below 0.02, so actually fairly consistent, which means that we can be quite confident no matter how many variations we do within this range, we will still be able to get good results in the classification and detection. And individually, our models show around 60 to 70% accuracy in detecting cancer patients for both 3 months ahead as well as 6 months ahead. That means that if for up to 7 out of 10 patients, we will be able to let them know 6 months in ahead that they are suspected as cancer patients, so therefore refer them to have additional tests done or maybe to a specialist to see what's happening. If we combine the metrics into ensemble, we can increase this performance for up to 8 out of 10 patients. And usually the performance of the other models that are in this area also goes around this number, around 80%. Our most recent work actually allowed us to get even more increased performance, more than 95%, even for 3 months ahead, once we actually add even more features in the data set. Not only that, we are actually able to show that the patients that are high at risk of not surviving the cancers are the ones that are actually classified correctly the most. So all of the models, as well as the combined version of the models into ensemble, thus place heavy focus on classifying correctly the patients that are high at risk of not surviving the cancer, which is actually quite good because those are the patients that need this early diagnosis the most. Not only for the cancer patients, but also for the healthy patients, for the control group, we do also have very high accuracy around the same range of 70 to 80% as well, which means that we may get some false negatives, and that's something that we can actually work on a bit more in the future. So what this research actually provides us is that we can use this kind of metrics from the pathology results in order to provide early cancer detection. They can be combined into a decision support tool that can be used by GPs, and we can specialize that based on more specific needs. For example, here in Australia, we have the main cities, but also we have lots of regional cities, and our latest research showed that these patients, because they get less frequent visits to the GP, they may have a bit reduced quality of data, but by focusing on that in particular, we are able to provide correct forecasts for them as well. And what's more important is that by using the methods listed before, like decision tree types, we can actually have a bit of explainable AI. So we can see exactly from the feature set that we created which metrics are the most relevant ones. And not only that, we are able to do this while handling all this uncertainty in the data, because patients don't get pathology tests very frequently, but just when they need to. And we are focusing specifically on the high-risk patients and providing ideas about methods that can be used by GPs without actually disrupting their current practices, which means this can all be done in the background and the GP just get the notification, making it very easy to implement in real life. And that is the end of my presentation. Thank you very much to everyone. If you have any question, feel free to ask.